If you are a medical student or a beginner physician and you want to have a simple, pragmatic approach to any patient, this video is for you. An important realization regarding the day-to-day work in clinical medicine is that it's very protocolar and empiric. Somewhat simplified, there are only two types of patients. The one that you're going to jump on and treat, and the one that you're going to have a nice conversation with. In this video, I'm going to talk about the former. Let's call it patient type A. When you meet patient A, your experienced nurses will hopefully react immediately and put your patient on a monitor so you can see oxygen saturation, pulse, blood pressure and an ACG. In the meantime, you're not going to stand and scratch your balls, and you're also not going to start with a detailed anamnesis. You're going to assess the airway first. Without a functioning airway, there is no effective ventilation, and without effective ventilation there is no oxygenation, and if there is no oxygenation, both you and patient are in trouble. The first question that should run through your head: does my patient have an airway obstruction? You deliberately have to look for signs of airway obstruction, like abnormal breath sounds such as stridor, paradoxical abdominal and chest movements, cyanosis, hypoxia, and so on. If the patient is conscious and able to speak, the airway is most probably not compromised at the moment. However, before you would move to the next step, you have to ask yourself, is my patient about to develop an airway obstruction? What I mean by that is that you also have to be able to recognize an impending obstruction, which may only have very subtle signs at the moment. For instance, the bradykinin-mediated laryngeal edema, retropharyngeal hematoma, smoke inhalation or laryngeal trauma can evoke a very rapid airway obstruction, and in such cases, the best strategy is to have a very low threshold for providing a definitive airway. If you see signs that the airway is acutely compromised, you have to act immediately. You will open the mouth. If there is a foreign object, you're going to take it out. If there is secrete, you're going to suction it, and you proceed to secure the airway. If you're not experienced in intubation and you suspect an airway problem, you should immediately call for help. You should also do something in the meantime, and you may be able to reach good oxygenation and win time with non-definitive airway management such as the chin lift maneuver, putting in an oropharyngeal or nasopharyngeal tube or laryngeal mask. In contrast to these measures, a definitive airway always involves a tube placed in the trachea with a cuff inflated below the vocal cords. There are only two types of definitive airways: intubation with an orotracheal or nasotracheal tube, and the good old surgical airway through coniotomy or tracheotomy. A definitive airway is indicated if you are unable to oxygenate the patient with other measures, if there is impending obstruction, aspiration of blood or vomitus, and a diminished level of consciousness. Let's say Glasgow Coma Scale under 9. In GCS under 6, you undoubtedly need a definitive airway. If the GCS is between 6 and 8, intubation may be a matter of discussion and you will need experience to make the decision. Nevertheless, in the trauma setting, ATLS suggests intubation in every patient with a GCS under 9. There's a dreadful situation that we have to talk about, the CICO. The acronym means can't intubate, can't oxygenate. Imagine a situation where your patient's oxygen saturation keeps falling and you can't intubate him and you can't improve his SATs via non-definitive airway management techniques. In general, you always want to see the SATs above 90. After a couple of minutes of inability to oxygenate and a failed attempt to intubate, you have to realize that your patient can't stay at saturation levels such as 50 or 60 for a very long time, and you need a surgical airway, in this case a coniotomy. If you would like to read about the difficulties of CICO, you may want to read the story of Elaine Bromley. You can find the link in the description.